The story I want to tell you is the story of contagious disease as it occurred in Kingston in the 19th century. Now, in order to tell the story, I'm going to tell it in three parts. The first part will be short, and it will be an effort to set the stage as to what had been achieved before the 19th century in regard to the control and prevention of contagious disease. The principal part of this story will be the story of contagious disease as it occurred in Kingston during the 19th century, and the response of the community to a remarkable development in the knowledge and understanding of contagious disease that occurred in the latter half of that century. And finally, recognizing what had been achieved in the 19th century, I would like to briefly tell you the story of what was happening in the first 2 decades of the 20th century. Now, in order to begin by before the 19th century, I'd like to use 2 examples of contagious diseases. And the first is plague, bubonic plague, which presents with fever, chills, and buboes. And you can see the characteristic bubo that was in the axilla or the groin, which made this disease so recognizable to the public in the past. Plague was a problem which plagued society throughout history, but there were 3 major pandemics which swept through the world, one in the 16th century, one in the 14th century, and one in the 19th century. The one example I want to use is the 14th century example of the plague that began in 1347 and came out of the Russian steppes and swept through the Crimea and the Mediterranean and slowly extended through Europe between 1347 and 1352. The characteristic of the spread was very important because the issue of quarantine had been used in epidemics in the past, but during this particular epidemic, because it spread very slowly, the characteristics of a quarantine were very firmly established, and particularly in the port cities of the Mediterranean. And it is in that time that the concept of quarantine for 40 days was established. That is the definition you'll now find in your dictionary today. And it began at that point in time. And the result was that in the European cities, there was quarantine of all ships for a period of 40 days, and caravans were kept outside for a period of 40 days. It was a very sophisticated form of isolation. The fact is, unfortunately, the people didn't understand the cause and the manner of transmission of plague. And the fact is, of course, the plague is transferred by the fleas of rats, and the rats ignored the quarantine, went ashore, infected the rats in the area community, and the disease spread very rapidly. However, the issue of quarantine was well defined and well established before the 19th century. The second issue is an example I want to use, the smallpox. And smallpox is a disease, as you can see in the picture there, that's characterized by pustules, and if the patient survives, result in scars. The mortality from smallpox was always quite high, something of the order of 25%. Smallpox came out of the eastern countries, and during the time of the Crusades and increasing trade with the East in the 12th century was brought to Europe. And by the 15th century, smallpox was endemic in Europe, and by the 18th century, it was the leading cause of death at that point in time. In the 16th century, smallpox was brought by the settlers to America, and there were repeated epidemics of smallpox throughout French and British Canada in the 17th and 18th century. Now, it had been known for a long time that if you survived smallpox, you were immune to a recurrence of the disease. And the Eastern societies established a procedure called variolation. And what this was taking a little bit of the pustule material and injecting it. The objective was to create a very mild smallpox infection and therefore thereby create immunity. The fact is that generally speaking it worked fairly well, although occasionally it would be very severe, and mortality from variolation was about 2%. However, there is a famous story of the bringing of the procedure of variolation to Britain and subsequently to America from Turkey, and variolation was used because of the concern of the mortality by many, because of the concern of the mortality from the naturally occurring smallpox. The reality is that in 1770 in Quebec and Montreal, James Latham, who was a military surgeon, used variolation on over 1,200 people, and later in that century it was agreed that the Mohawk Indians around Kingston could be variolated if they wished. But generally speaking, there was a resistance to variolation because people were concerned about the possible risk. The big break that occurred just before the 19th century, of course, was the discovery and the reporting by Edward Jenner of the protective effect of cowpox vaccine. And it's very interesting. John Clinch, who was in Newfoundland, was a classmate of Edward Jenner and received some cowpox vaccine from him directly and used cowpox vaccine in 1800. So as we enter the 19th century, we have, against a background of an appreciation that from the point of view of control, quarantine was a technique that could be useful, and the first initial resource to prevent contagious disease, in this case smallpox, was now available. Now, Kingston in the 19th century was a small but important urban community. Around 1820, it had a population of about 2,500, with the military over on the other side of the river around Fort Henry Hill. In order to begin to tell this story, I'd like to introduce to you John C. Clark. Now, John C. Clark was born in 1878 in Ernestown Township. He was a very well-educated man, and he lived in the Kingston community throughout his life. The important thing about John C. Clark was that he kept, from 1830 to 1864, when he died, a daily diary. Now, the purpose of the diary, which is a copy of which is available in Queen's Archives, was to document the weather each day, which he did. But he also would document events that occurred in the community, and particularly events that were related to illness, marriages, and deaths. And as such, his diary is a very interesting document to read. Now, one of the things that he addresses in his diary was the very high mortality that occurred in infants, children, and young adults due to tuberculosis. And as he described it, in his community, whole families might die of consumption. Puerperal fever or childbirth fever. John had 2 daughters and 1 daughter-in-law who, following delivery, had childbirth fever, of at least one of whom died. And also the endemic contagious diseases of typhoid fever, diphtheria, scarlet fever, and measles. And we'll come back to those ones again. At the same time, in the 18th century in Canada, there were periodic outbreaks of smallpox that occurred across the country. And they were particularly devastating to the native people who were naive to this infection for the first time. And very often the mortality in the native people would be the order of 50% rather than 25%. But the other issue which was superimposed on all this were the epidemics of cholera and typhus that occurred during the 19th century. Now, at that time, health care was provided in the home. And in Kingston, there was not an institutional facility available for the provision of health care. The first resource that was available was a female benevolent society. It was established in 1820, who used to maintain a temporary hospital and a blockhouse from November to May for the urban poor. Otherwise, there were no healthcare resources other than what was available in the home. Now, there's a very important thing that had an enormous impact on the Kingston community, and that was the immigration that occurred to British North America in the first half of the 19th century. And these are figures that represent the years 1815 to 1855, and I'd only draw your attention to 1832 and this bar, and 1847 and this bar. Now, cholera is a disease that we're all suddenly become aware of again, but because of the events in Haiti. But cholera was characterized by mild to severe diarrhea, and the unique characteristic of cholera in the 19th century was the fact that it could be very severe and lead to very rapid death. That created an enormous problem. Cholera in the 19th century was to the world of the 19th century what smallpox had been in the 18th century and plague had been in earlier years. And in the 19th century there were a series of pandemics that swept through the world, beginning in 1832 until 1866. And the mortality varied from 30 to 80%. And this cartoon, which was in a publication in Paris, reflects the awareness of the community of the remarkable mortality associated with this particular disease. Now, in 1831, the first pandemic, the disease had reached Britain, and the people in North America were aware of this, and throughout the spring of 1862 were anticipating that they too were going to face the problem of cholera. And in fact, in 1832, the first cholera was documented in Quebec City. Within 4 days, it was in Montreal, and by June the 17th, it was in Kingston, and by June the 20th, the first death had occurred in Kingston. Now, the physicians, generally speaking, were military physicians or naval physicians, and the military and naval physicians had had long experience of the contagiousness of infection when they were looking after the military in barracks or the ship, the crew on naval vessels. And they were committed to the issue of hygiene and cleanliness. And so when this story came, the physicians responded. And the Commodore of the HM Dockyard in Kingston initiated this sequence of activity. It is my orders that as a preventive measure, all communications with immigrants is to be avoided and as little intercourse as possible kept with Kingston. It is my direction that all the cottages and inhabited shanties are forthwith thoroughly whitewashed inside and the yards attached immediately cleansed, and that the quality of quicklime be thrown in the filth of each of the privies. He also expected a high level of hygiene, personal hygiene, on all the people in the dockyard. And the dockyard remained in superb isolation from the cholera epidemic when it finally arrived. Now, the Kingston garrison did essentially the same thing. Their problem was a little more complicated They carried out the same cleaning of the barracks and whitewashing of the barracks, but many of the military had families who were living in Kingston, and they had to transfer those soldiers from town up to Fort Henry Hill. And when the epidemic arrived in Kingston, the barrack gates were closed and the military were isolated. They in fact had 36 cases of cholera and 5 deaths. They didn't entirely avoid it. Now the physicians in the community were almost always those who had been in the military before, and they had essentially the same philosophy, and generally speaking made up what was the initial Board of Health in Kingston. Insofar as they could, they endeavored to cleanse the town. They set up a tent hospital which was supervised by a military surgeon, and they quarantined the harbor, and ships had to be inspected before they could land. In spite of their efforts, by the 15th of August, the local newspaper reported 212 cases with 78 deaths, about 40%, which was sort of in keeping with what was happening with cholera elsewhere in the world. And by the time this particular epidemic had run its course, there had been 200 burials in Kingston. Now, cholera came back in 1834, 1849, and 1854. In 1834, cholera paralyzed trade in town. The tradesmen wouldn't come into town, and all activity essentially stopped. Robert Drummond was an interesting person. He was an entrepreneur who actually was responsible for building the lower end of the Rideau Canal system. And Robert Drummond had his first signs of illness at midnight, and he was dead at noon. The response of the community was that a society for the relief of widows and orphans was established, because that was becoming a significant problem within the community. And by the end of August, the Christian Guardian had reported 200 burials in Kingston at that time. Now, John Clark, in 1849, noted in his diary that cholera was in most of the cities and towns in Upper Canada. And on July the 30th, he reported that many deaths had already occurred in Kingston. In 1854, again, John Clark noted in his diary that cholera was bad in Kingston. But it also had a very personal impact, and his son-in-law on July the 8th died after 3 days' illness due to cholera. John Balmer, in his personal writing, noted that he was aware of several men who went to work in the morning and took sick and died before returning home. The nature and aggressiveness of the cholera really was a devastating concern to the community. And this results, as often happens in cartoons that tried to reflect the sense of concern that people had in regard to the occurrence of cholera. And here we have an emaciated patient. The only treatment he has is repeated emetics or cathartic pills, which is undoubtedly the wrong treatment for the disease. And Fee-Fi-Fo-Fum is sitting down here waiting for this emaciated patient to die. That was the attitude that people had. The cartoons tell us a great deal about the personal beliefs of the folks involved. Now, the second major epidemic that came to Kingston was typhus. Now, typhus was a disease that was prevalent in the 18th century and 17th and 18th century because shiploads of immigrants or commercial shiploads would arrive in Quebec City, And the sisters would be inundated with patients with severe fever, cough, and abdominal pain, which at that time was referred to as shipboard fever. However, in 1847, and you will remember the long column on the immigration graph, in 1847, it is difficult to get a precise expression of the magnitude of the problem. However, there was a special committee of the executive committee of the established government at that time who carried out a study. And they obtained information of the manifests of ships that left the British ports, plus information from the boards of health and the established communities, particularly Quebec, Montreal, Kingston, and Toronto. There were, from the British ports, 89,000 immigrants that left the British ports. Many of them in 1847 were Irish immigrants who were trying to escape the Irish famine, which was ravaging the country at that time. Of those 89,000 who came on a variety of different vessels over a period of time, 5,000 died before they arrived in Quebec and the Isle of Orleans. In the total figure, the overall figures, there were 30,000 people reported to be ill with typhus amongst this immigrant group, and 10,000 died. That is roughly 30%. Now, insofar as Upper Canada is concerned, in 1847 there were 38,000 immigrants who left Montreal and came down the river and had to go through Kingston to arrive at whatever destination they were aiming for in Upper Canada. Between Kingston and between Kingston and Toronto, there were identified by the Department of Health 8,000 admissions, or people who were sick with typhus at the time they arrived. And of those, in other words, 1 in 2 of the people, 1 in 5 of the people who came were sick when they arrived, and of those that arrived, 1 in 4 died. And the end result was that Kingston was devastated. And if I was trying to create a sense of perspective, remembering that Kingston was a community of about 10,000 souls at the maximum at that point in time, and they dealt with 38,000 people who came through the waterfront. That would be similar today in our community if we had 600,000 people arrive at the waterfront. For the people in Kingston, that was an overwhelming impact that they were exposed to. The resources were very limited, and the best they could do was a series of fever sheds along the waterfront. And for those who died, they all were buried in a common grave right beside the Kingston General Hospital. And many of you are probably familiar with the Angel of Mercy, which was, in fact, beside the Kingston General Hospital for a long time to mark that common grave, but is now in St. Mary's Cemetery. So I'd like to leave with you a sense of the tremendous impact that illness was having and the epidemics superimposed on it was having on the society that lived in Kingston at that point in time. Now, the people in Kingston recognized in the 1820s that they did need to have a facility of some kind and were keen to see a hospital created. In the late 1820s, there were 80 members of the Kingston community who pledged £1,000 toward the construction of a hospital. And in 1833, the government of Upper Canada finally gave them a grant of £3,000, and this building, the main building of the Kingston General Hospital, was built and completed in 1835. However, as so often happens, they had the building, but they didn't have the funds to either furnish it or operate it. And in fact, although there's an interesting story, it wasn't until 1845 that the hospital was opened as a charitable general hospital, which was incorporated in 1849. And again, its purpose was to relieve the conditions of the sick and destitute immigrants and the mariners of the lake. In other words, at this point in time, what Kingston had was what most communities in the Western world had. It had a philanthropic hospital for the care of the poor and the indigent, but it did not have an active treatment hospital. Now, over the next 30 or 40 years, there were a number of events that occurred that really led to the transformation of the role of a hospital from a charitable institution to an active treatment hospital. And these changes began slowly, and they evolved slowly over that period of time. The first real change that occurred here in Kingston was that the medical school was established in 1854. And the end result was that the physicians, there were physicians in the hospital because that's where their instruction occurred, and they were there also to provide patient care. The end result was that there was slowly a change in attitude of the public toward the hospital, and an increasing number of patients began to come to the hospital. And because of the increasing requirement for patient care within the institution, there was a need to expand the facilities. So in 1862, the Watkins Wing, this wing here, was built onto the main building, and the Watkins Wing had some smallpox wards in the basement, which was the wrong place to put them, and they soon took them out. They had wards for patients on the first floor, and they had an amputation theater on the second floor, because that was about all the surgery that was really done at that point in time. Now, I'd like to introduce you to a friend of mine for whom I have the greatest respect. Kenneth Fenwick was born in Kingston. He was graduated from the medical school here in 1874, and he returned to the faculty and was a member of the faculty. And for the last 11 years of his life, before his very unfortunate death, he was the professor of obstetrics and gynecology. Clearly a very wise fellow. But Kenneth Fenwick did a lot more than good obstetrics and gynecology. He played a role in regard to two things that had a great impact on the evolution of hospitals. When he was in London in 1874, the work of Lister in regard to antisepsis and the dealing of surgical open wounds was being very actively discussed. And he came back to Kingston as a firm advocate of antisepsis and surgery, and the use of asepsis in the preparation for surgery. And he advocated and vigorously introduced those practices in the hospital for the first time. The second thing he played a great role was in regard to nursing. And as we all know, the development of nursing, not that nurses hadn't been available in the orders, the Anglican and Roman Catholic orders, but the development of nursing as a major profession followed upon the work of Florence Nightingale and was highlighted by the experience in the American Civil War. And it was recognized that nursing offered a great deal to the care of patients in hospital and had a going to have a very positive impact in regard to the outcome of patients. And Kenneth Fenwick was very committed to this, and he was the one who recommended to the Board of Governors that the Kingston General Hospital establish the Kingston General Hospital School of Nursing, which was established in 1886. Now, the biggest thing that happened in the last half of the 19th century was that the cause of contagious disease was finally unraveled. And historically, it had been assumed that contagious disease was a product of bad air, and that bad air carried something which caused these particular diseases. Well, we know that the microscope was established and developed in the 18th and certainly in the 19th century, and it was the window that opened the golden era of microbiology in the last half of the 19th century. And what really happened was that over the last 2 decades of the 19th century, the cause of most of the diseases, those associated with animal vectors, plague and typhus, those associated with waterborne infection, cholera and typhoid fever, and those associated with airborne bacterial infections, diphtheria and scarlet fever, were identified. The specific causes were identified, and the means of transmission were determined. And so the understanding of contagious diseases was really revolutionized, and in that context, obviously great changes occurred. The viral infections, of course, were recognized as contagious diseases, but the virus themselves had to await the electron microscope in the 20th century. Now, the interesting thing is that contagious diseases were a problem not only in Kingston but elsewhere in the world. And they were a particular problem in Britain. And they were a problem in Britain because of the Industrial Revolution and the enormous movement of people from the rural communities into the cities to find work. The end result was there were large concentrations of people, often in ghettos of the cities, who were really meat and potatoes for contagious diseases when they came along. The end result was that in Britain, as also occurred on the continent, they began in the late 1860s to begin to build small and large fever hospitals. And by 1885, there were well-defined plans of how a fever hospital should be set up. And this is just a small example of what they did. And this was a totally separate unit. You could only entrance and exit. There was a nursing station with a window to observe 2 beds in a ward here, and a similar unit on the other side. And that's what they used in small cottage hospitals. In the larger hospitals, the mechanism began to be expanded, and they had larger wards, but the same principle. Each unit was isolated from the other units, and there was a nursing station set to observe the patients on both sides. Now, in 1889, the Board of Governors at the Kingston General Hospital recommended that a new building for the management of infectious diseases should be built. Their only problem was they didn't have the money. Now, in 1890, my friend Dr. Fenwick was in London, as he often did, and he visited many of these fever hospitals, and when he returned, he was a member of the building committee that led to the construction of the Nickle Wing. And this is the Nickle Wing here on the right-hand side of the main building, and this is the Watkins Wing here. And what happened is that William Nickle, who lived in a house next door to the hospital, the house that's still there, was a governor. And he died in 1890, and in his will he left his wife $10,000 to be used for philanthropic purposes. And his wife decided to give the $10,000 to the Kingston General Hospital to build this building. And therefore it is known as the Nickle Wing. The construction began in 1890, and in 1891 it was opened. And in the local newspaper it was described as the most complete hospital in the country for the treatment of infectious disease. And that was probably true. It was probably true that it was the first facility which was totally designated to deal with contagious disease. Now, this picture here was probably taken about 1895-96, because when it was first built, these two bridges here to the main building weren't there. And so the infectious ward was on level 1. This is the ground level here, and this is level 1. So I see. So I see it's died. Oh well. Maybe I should stop. At any rate, on the second floor there were 9 rooms with 19 beds, and the rooms were all designed in order to keep them very clean. The corners of the room were all angled, and the floors were marble. And everything was focused on cleanliness in order to maintain a high level of protection in regard to the transmission of contagious diseases. Now, in the building, based on the experience in Britain, they established what was known as the Smead Dowd ventilation system. And this system was designed to give individual ventilation to individual rooms. And so that each room was separately ventilated with exits beyond the room. And so it was viewed as being a very sophisticated facility for that period of time. Now, the first 8 years of the Nickle Wing, I have the death registries, but I don't have the admission registries for the Nickle Wing in that period. But what we do have is we have the minutes of the Board of Governors. And the minutes of the Board of Governors at almost every meeting addressed the issue of contagious diseases as it was occurring in the Nickle Wing. And two things emerged. One was that there was a very large number of cases of diphtheria and scarlet fever, and that they were being asked to admit. The second was that there were deaths occurring in the hospital in isolation. There were 25 deaths in that 8-year period in typhoid fever, and there were 17 for diphtheria and just 1 for scarlet fever. However, in 1899, at the end of that period of time, from the point of view of the Board of Governors, there were 2 major issues. One was that the design of the floor was not satisfactory to deal with a large number of cases of diphtheria and scarlet fever. The second was that the heating system, in spite of repeated efforts to improve it, was a disaster. And so their recommendation was that in 1903 that alterations to comply with the requirements for isolation of contagious diseases had to occur in the Nickle Wing. Now, this is a plan that for the isolation that was proposed by William Newlands, and well, my pointer is working. There are 4 sections to the floor. All 4 sections are separate. They're independent of one another. And you can see faintly the larger wards for diphtheria and scarlet fever, and individual bed rooms for other patients and for the nurses. The Board of Governors, again faced with the problem of not enough money, said that they had to do something, so they went ahead, and these renovations were completed in 1904. Now, Miss Flaws, who was the matron of the hospital, invited the chair of the Board of Health to come and review the renovated Nickle Wing. And the board chair came with the medical officer of health and with the sanitary officer. And these are 2 excerpts from his report. I visited the isolation wing of the general hospital and found the structural conditions of this portion of the hospital apparently good. The system of ventilation of the 2 sets of wards being separate precludes the possibility of infection being carried from one set of wards to the other by this means. But then he made a second statement, which I think is very important. I found the structural precautions to isolate this wing from the main building good for this system, but it can never be as efficient and thorough as where contagious diseases are cared for in separate buildings in conformity with the Public Health Act of that time. And I'll come back to that later. Now, some regulations were set up in order to maintain this isolation, and it was required that all refuse that came out of the Nickle Wing had to be burned. The house surgeon in the Nickle Wing was required to occupy a separate sleeping apartment, and the nurses in the Nickle Wing could not leave to the other part of the hospitals until the throat cultures were negative for diphtheria. A very sophisticated set of guidelines. So that brings us to the end of the 19th century. So where were we at this point in time? Well, there are 3 things that I would like to speak to based on largely the experience in the first 2 decades of the 20th century. The first thing that happened was that the foundation of the public health system as we know it today was established. Departments of health had been established in many communities because of the epidemics that had occurred in Upper Canada or Ontario in earlier years. But in 1882, the Department of Health for the province was established. In 1884, the first Public Health Act for Ontario was legislated. And between 1884 and 1889, there were a series of amendments of the Public Health Act that dealt directly with the control and prevention of contagious diseases. So the foundation of the public health system upon which we rely today was laid in these particular years, and that was a very important development. I'd like to speak very briefly to vaccination and quarantine as it occurred at that time, and then I'd like to give you some insight of the continuing nature of contagious diseases as it occurred in the Nickle Wing. And for this period from 1900 to 1922, I have the admission records and the death records from the KGH archives for that period of time. Now, smallpox was continuing in the province. There were frequent outbreaks of smallpox, And particularly in the latter part of the 19th century, the native people of the West were being devastated by epidemics of smallpox. There is a very interesting book written by Michael Bliss about a major outbreak of smallpox that occurred in Montreal in 1885. And this is probably the last very large epidemic that occurred in Canada, although there were subsequent outbreaks. And what happened in Montreal is that in a very short period of time, a period of 4 months, there was a massive outbreak of smallpox with 3,000 deaths in a very short period of time. And it's a very interesting because the background of this outbreak was the fact that the Francophone community in Montreal were very resistant to vaccination. And therefore there was a large naive population in Montreal, and when it arrived, it had a devastating effect upon the community. In Ontario, according to provincial statistics, that in the period 1884 to 1904, there were 6,500 cases of smallpox in Ontario. So smallpox had not gone away by any manner of means. Now, Kingston was, in many respects, very fortunate. According to the minutes of the Board of Health, who were responsible for the care of smallpox, because smallpox could not be admitted to the isolation hospitals, but was supposed to be admitted to separate institutions. Therefore, the Board of Health had to assume the responsibility for those cases of smallpox that arrived in Kingston. And in the last few years of the 19th century and the first few years of the 20th century, the Board of Health had to deal with 2, 3, 4, 5 cases of smallpox each year, and they had to find some isolation facilities. Now, the Board of Health was constantly asking for a separate facility for smallpox. And the only real facility was available was an abandoned hospital, military hospital on the east side of Fort Henry Hill, which had been used by the military when they were still here prior to their departure in 1871. The Royal Military College continually, and the Department of what's the War Department? French? Rejected their requests for this because RMC did not want to have smallpox in their backyard. So we've heard that story before, and it came up again at this point in time. But generally speaking, Kingston was relatively fortunate in relation to the occurrence of smallpox. However, the efforts in regard to vaccination were being vigorously advocated by the Provincial Department of Health and by the municipal departments of health. And in 1897, the provincial legislation required that the council of each city and town be empowered and required to contract with some legally qualified, competent medical practitioner for vaccination at the expense of the municipality for the poor and those who could afford to pay. So they were very active in regard to creating the opportunity for vaccination. But we must remember there always was and there always has been an anti-vaccination lobby. And I don't know whether anyone heard the news last night, but the Supreme Court in the United States rejected a request by a vaccination group to sue the pharmaceutical company because of complications due to DTP. So the issue is that the community was actively endeavoring to assure that vaccination was available and was practiced as widely as possible, because they viewed it as the best way to eliminate the problem of smallpox, which ultimately proved to be true. Now, in regard to quarantine in contagious diseases, the same kind of legislation was occurring, and in 1899, the Board of Health in Kingston established this requirement. Whenever a case of contagious disease exists in any house, the householder shall, within 18 hours after the time such disease is known to exist, notify the head teacher of such school and also the secretary of the local board of health. And no member of such household shall attend school until a certificate has been obtained from the medical officer of health or a legally qualified practitioner that infection no longer exists in the house. This is a very high level of community quarantine. And some of us may well remember the fortunate chums who were in a house with a card in the front window that they couldn't go to school because they had chickenpox or smallpox or chickenpox or measles or something of that kind. A practice that did continue for a long time, but certainly doesn't exist today. So at this point in time, a very high level of quarantine was being established within the institutions and within the community in regard to contagious diseases, the diagnosis of which were much more highly recognized. Now, there were a number of contagious diseases that continued in the first 2 decades, and this reflects the experience in the Nickle Wing between 1900 and 1922. Now, typhoid fever is characterized by fever and diarrhea, and during the 19th century, throughout North America, the mortality would range from 5 to 20%. The issue of the cause of typhoid fever had been, the source of typhoid fever had been identified by William Budd in 1856 in an epidemic that occurred in Bristol, where he concluded the disease was due to fecal contamination of water. And the end result was that there was an understanding of the enormous importance of clean water and the potential, in the absence of satisfactory sanitation, to have polluted water. And the pollution occurred either from privies to wells or from the influx of pollution into our rivers and lakes from which the source of waters were being drawn. In the Nickle Wing between 1900 and 1918, I don't have the admission records for 1920. It's an interesting story if you're interested in archives. But these are the admissions that occurred each year over that period of time. There was a total of 861 patients admitted with typhoid fever, averaging about 45 per year. The mortality was particularly significant in relatively young adults and ranged from the age of 10 up to 40 years of age with some older patients. Mortality in that period of time due to typhoid fever was 6%, which was pretty good in that particular era. There was a great recognition in the community and by the Board of Health in regard to the importance of water and sanitation. And if you read the minutes of the Board of Health for Kingston from 1895 to 1915, there isn't a single meeting that they didn't talk about water and sanitation. Now, the Water of Kingston was a private company, was commissioned in 1849 to establish the pump house where the current pump house is. And it operated for a number of years relatively unsuccessfully. It served a very small part of the community. And in 1887, the city purchased the pump house and actually enlarged it. And this is the pump house as we know it today, which is a product of the enlargement that occurred in 1887. When they were finally beginning to bacteriologically test water, because that was possible, they established in 1894 that the intake pipe was drawing water from polluted water. And so the intake pipe was extended another 1,700 feet in an effort to get out to cleaner water. The Board of Health didn't have a meeting, that they weren't required to review a well in the community and establish that it was polluted and that could no longer be used. There was a very interesting detective story of typhoid fever that was a product of milk, and they traced the source of the typhoid back to the well that the dairy was using in the production of their milk. At the same time, there was not a meeting of the Board of Health that did not discuss some major deficiency in the sewer system and submit a request to the city that something urgently be done in an effort to improve either the linkage to the houses or the drainage of this sanitary system. So the level of concern in the community was very high. Now, diphtheria, which is a disease that many of us probably never see today, but associated with fever, sore throat, and difficult swallowing, was endemic in the 19th century and was associated at that time with a very significant mortality of about 15 to 30%. Scarlet fever was characterized by fever, sore throat, red tongue, and a rash, and again had a mortality in the 19th century up to about 10%. Now, this is the pattern of admissions of diphtheria in blue and scarlet fever in yellow, and it's evident that there were outbreaks in different years of these two diseases, and they cycled up and down. So that during this period of time, there were 898 patients with diphtheria admitted to hospital, averaging about 47 per year. Scarlet fever, there were 645 admissions during this period of time, averaging about 34 per year. So it was a significant problem that the isolation facility was required to deal with. Now, the mortality due to diphtheria and scarlet fever was almost all restricted to infants and young children. The vast majority of the mortality in diphtheria and scarlet fever were in infants and small children. The mortality rate in diphtheria for those patients admitted was about 4%. And that really was quite good. And that probably was a product of the fact that the diphtheria antitoxin had become available in 1895 and was being used in the treatment of diphtheria as long as they saw the patient early in the course of their therapy. The mortality due to scarlet fever was about 2%. Now, influenza is a disease that we're all familiar with and various manifestations. And it too occurred repeatedly throughout North America. Kingston did not seem to be seriously impacted, at least to the level requiring hospital admission, in the early part or the first decade of the 20th century. However, in 1915, there was a surge of influenza admitted to hospital. In that period of time, although the number of patients admitted were becoming significant, in fact, there was no mortality. However, in 1918, between August and October, there were 436 cases of influenza admitted to hospital, and 38 or 10% died. And that was the Spanish flu of 1918 that swept throughout the world and arrived here in Kingston and operated in essentially the same way as it did everywhere else in the world. Now, measles and mumps were frequent occurrences. Generally speaking, they were probably handled in the community, but as the years went by, more and more of these patients would be brought to hospital. And we had a large spike of measles beginning about 1915, and a similar spike of mumps. Generally speaking, mortality was quite low, but there were 6 deaths due to measles during that period of time. Well, what can we conclude from this? Well, the first thing we conclude is that Kingston, as elsewhere in the world, has been challenged by contagious diseases before, during, and since the 19th century. The world has not changed. The remarkable thing that happened during the 19th century were a number of factors that led to the transformation of the hospital, of which probably the most important was the knowledge of the cause and transmission of contagious diseases based on the germ theory. This was a major step forward. The next thing that was very important, a product of the 19th century, was the creation of the municipal and provincial departments of health with legislation for the control and the prevention of contagious disease. That has been very important and is still extraordinarily important to us today. In regard to control, I would suggest to you that at the end of the 19th century, they had reached a pinnacle in the quality of quarantine in hospitals, at least in Kingston, and quarantine in the home. Patients in the community who had diseases were responsible not to spread the disease. They had to stay in the home. In regard to prevention, it was firmly established that water and sanitation was the key to the waterborne infections of cholera and typhoid fever. The experience in the Nickle Wing indicates that by 1922, Kingston had not yet reached the point of providing safe water for all the community, and typhoid fever was continuing to occur in exactly the same way as it had at an earlier time. Now, to digress just for a moment, one of the interesting things that happened was that the Nickle Wing as an isolation hospital was closed in 1922, and in 1923 they built the freestanding separate isolation hospital that some of you may have been familiar with, which was on King Street right next to the hospital. And Marilyn will remember it very well. She worked in there for a while. And that was the pinnacle in Kingston of a freestanding isolation hospital separate from all the other hospital facilities. Vaccination had become an established principle as far as the profession is concerned, and for much of the community as far in regard to smallpox. But the fascinating thing that began to occur at the end of the 19th century was the development of vaccines for these other contagious diseases that they now understood. and the remarkable development of vaccines that occurred in those 2 decades have eliminated for us, as we know it today, the problems of diphtheria, which we don't see anymore. So the 19th century was, from the point of view of contagious diseases, a very exciting time. And it led to a remarkable transition that those of us today should be extraordinarily grateful for. Thank you very much.